Great. So thank you for inviting me along today. I will be speaking about food allergy in the skin with a focus on, I suppose, the non-IgE allergy and the nutritional side of things as well. So I suppose to get started, an introduction, we'll cover a little bit of the background of allergy, non-IgE mediated allergies, so the delayed reactions, the nutritional consequences of dietary exclusions, and skin problems during the introduction of solids. So first of all, I suppose eczema, which I know you're going to hear more about later on. Just to mention, as you know, it's a skin barrier defect resulting in red, itchy, inflamed skin. It's very common in childhood. We know up to, I suppose, 10 to 20% of infants will have eczema at some point. But I suppose the school of thought at the minute is that food allergy does not cause eczema. So food allergy is present in 3 to 5% of the population. So it's not that everybody who has eczema has food allergy. And I suppose the most recent Cochrane review on this subject is that there's no convincing evidence that egg and dairy-free diets or a few food diets or elemental diets are beneficial in eczema treatment. But I suppose what we do need to consider is, as Professor Warren was saying, eczema is thought to increase the risk of food allergy. So I suppose if we're thinking of taking things out of the diet, we need to be mindful that we're not going to be increasing the risk of developing allergy then later on. So especially in, I suppose, those high-risk infants, so infants with severe early onset eczema, so it'd be less than 3 months, and the very high-risk infants, so the severe early onset eczema, and then with an existing allergy also. So these are the, I suppose, the group of infants that I would be reluctant to take anything out of the diet unless there was a very good reason to do so, because I suppose you could be making the problem worse by giving them a greater chance of a significant IgE mediated allergy. So I suppose as an allergy overview, Professor Warren, he was speaking a lot about, I suppose, the IgE mediated allergies. So those that have an immediate onset, so within 2 hours, things like acute urticaria, angioedema, coughing, hoarse throat, and sometimes vomiting. And then also anaphylaxis would fit into that group as well. What I'll be speaking about is the non-IgE mediated set of allergies. So I suppose our typical non-IgE mediated that we'd come across in the community and in clinics. Not so much, I suppose, about the food protein induced enteropathy and FPIES, which is a different area. And I suppose while I'm here, I just wanted to mention that lactose intolerance is in a completely separate group. And I suppose it is generally quite rare in the Irish population, specifically in infants. So I suppose it would most commonly occur maybe after a GI bug or something like that. So I suppose I would be maybe thinking of that less often than perhaps the non-IgE mediated allergies. So in terms of our signs and symptoms for the non-IgE, so as I said, they are a delayed reaction, so usually occurring 2 to 72 hours after ingestion. Because of this, it makes it a little bit tricky to say, I suppose, is it the food that's causing the reaction or is it something else? And I suppose our symptoms can range in severity. They are usually quite gutty in nature. So I suppose if we think of our babies that maybe present with blood and mucus in the stool, frequent loose stooling, so diarrhea, constipation, sometimes with, I suppose, soft stool constipation, so where they're straining and producing soft stools, vomiting, those really colicky babies, and then I suppose food refusal, faltering growth, and then non-specific skin symptoms such as erythema, eczema flares can also, I suppose, fit into that category. But I suppose the main thing is that the symptoms, I suppose a lot of these symptoms can be quite vague and are present in, I suppose, a good percentage of the infant population. But I suppose where we might be thinking non-IgE mediated allergy is maybe in the group of infants who these symptoms are persisting despite their, I suppose, the first line measures that would be there for the treatment of them. And I suppose the more symptoms they have, the more likely that it is a non-IgE mediated allergy. So I thought it would be useful to have a bit of a case study. So I'm sure many of you have come across cases like this in your work. So if we take a 4-month-old baby, you've noticed, I suppose, that they've got poor weight gain. It's not necessarily at the point of faltering growth, but their weight is plateaued a little bit and become a little bit static over the past while. And mum's main concern, I suppose, at the minute is baby's eczema on its cheeks and neck. I suppose it's a predominantly breastfed baby, and mum is coming to you for advice. She's thinking of excluding all milk and egg and nuts from her diet. So I suppose lots to think about there. So I suppose what do we want to know? Where do we go from here? So I think getting a little bit more of a history is really important. Understanding, are there other symptoms? So perhaps mum is then saying that, yeah, okay, there is lots of loose frequent stooling with mucus there, and baby is a very kind of fractious and unsettled baby and doesn't really sleep awake at night. And then the onset of symptoms. So I suppose, are there any symptoms that are immediate, happening within, I suppose, minutes to an hour or two after feeds, or if the baby's on any solids at this point? And then I suppose thinking, is there anything that has changed in the diet in the past couple of weeks? Have they started weaning? Or as mum said, she's predominantly breastfeeding. What else is she using? So is she using any formula top-ups or anything like that? So I suppose optimizing skincare is always going to be your first line. So regular emollients, steroid cream if indicated, and I think you'll be hearing a bit more of that later on. And then I suppose from the history, if you're finding, yes, there is multiple persisting symptoms, then we would be considering, okay, do we trial an exclusion of something or another? So if we go back to, I suppose, our case study, we find on the history taking that, yeah, there's poor weight gain, the weight is plateaued a little bit, baby has eczema, mild, moderate, and then also we said the loose frequent stooling, predominantly breastfed, but there have been some formula top-ups introduced over the past 4 to 6 weeks. And mum's wanting to exclude all milk, egg, and nuts from her diet. So I suppose when we're looking at the problems here, we're thinking, okay, is there any link between introducing the top-ups, the formula top-ups, and any of the symptoms? And then we find out from mum that yes, actually, the nappies have got a lot worse, and sleep has gotten a lot worse, and weight has plateaued over the past couple of weeks since the formula top-ups have been increased. So I suppose what we'd be saying is if it is at all possible, can we return to, I suppose, mostly breastfeeding, and then supporting mum with that, I suppose, to help with the weight gain side of things as well. So yeah, maximizing breastfeeding time and ensuring mum's nutrition, hydration, and considering things like pumping and that to ensure there is supply there. And perhaps using express breast milk top-ups instead of formula top-ups, if that's, I suppose, what is going to work for the family. And then I suppose in relation to mum wanting to exclude milk, egg, and nuts from her diet, I would be saying there's no real indication for that at the minute. I'd be saying let's get rid of the top-ups first, seeing as that's when I suppose the problem seemed to get worse. And then we're going to be obviously monitoring and seeing how baby goes. Again, so I suppose before making any changes, I suppose we want to see that there are maybe skin symptoms plus GI symptoms. It's a bit of a risk assessment. We want to see that is it going to be worth taking something out of the diet to actually see that yes, there is an improvement. Baby is gaining weight, growing, thriving, no longer having 12 dirty nappies a day, and they are a little bit more settled in themselves, rather than, I suppose, risking taking things out that don't need to be taken out. So I suppose in relation to the breastfeeding mums and non-IgE milk allergy, if we are going to be excluding foods, it's really important to suggest a trial period. So usually that would be at least 3 to 6 weeks. So 6 weeks probably being the maximum end of the scale. And we know that we need this time to, I suppose, see if there is a beneficial effect. I suppose given the natural course of eczema, it does wax and wane. So you need to have a decent period of time to actually see, is there an improvement? Really important that it is a complete and thorough avoidance of the food. There's no point, I suppose, if you're doing this to just be avoiding kind of having milk as a drink. There needs to be an exclusion of foods as well that do contain dairy in them, so perhaps baked dairy, and that from the mum's diet as well. There is very little evidence for excluding any foods outside of milk and soya. So that would be kind of our general approach. We wouldn't be saying to introduce eggs or to exclude eggs and nuts as well as milk and soya. It would be a stepwise approach, and knowing that I suppose it's a really, really tiny percentage that would notice any change with further exclusions. For breastfeeding mums, really important to find replacements for the excluded foods. We're looking in that there are loads of options, I suppose, available on the market at the minute. It seems to be anything that's out there you can make a milk out of these days. So there's oat, coconut, almond milk, pea milk, hemp milk, I suppose loads of different choices, but I would be saying to avoid the organic ones, which is counterintuitive for many people. But the reason being is that I suppose they're not fortified with the calcium and the vitamins and minerals that is present in our regular dairy milk. And then I suppose mum may need a calcium supplement for bone protection as well. And to get an idea, I suppose, of what breastfeeding mums need. So it's around 1,000 milligrams of calcium a day. So what does that look like? So that's going to be, I suppose, your serving of milk in your breakfast in the morning. It's going to be a yogurt, some cheese, not the whole block, but maybe a matchbox size piece, and then another portion later on. So a glass of milk or another yogurt, whatever it may be. But I suppose it is a decent amount of calcium-rich foods that is needed in the diet to meet the requirements. And if we're taking that whole food group out, we are running the risk that they're going to be deficient. And we know that, I suppose, in breastfeeding, the calcium in the breast milk is prioritized. So if there's no calcium coming from mum's diet, the calcium is going to come from the process of bone resorption. So I suppose for women, we want to prevent the risk of osteoporosis, osteopenia. So just important that there are alternatives in there as well. We can't just take the whole food group out without replacing it with something else. And then I suppose after the exclusion period, really important to have a reintroduction period, and this is to confirm the diagnosis. As I said, with non-IgE allergy, it is really hard to know, is this just regular baby, things like colic, a bit of eczema, difficulty feeding, or is it something that actually is a non-IgE mediated allergy? And equally, I suppose, if there is lots of blood and stool in that and it's not improving with the exclusion diet, or if it's getting worse at any point, it does need medical attention because it mightn't be related to the food. So would be gradually reintroducing the food following the exclusion period in non-IgE allergies. If symptoms return, that's likely our diagnosis of a non-IgE mediated allergy. And then from there, I suppose it would be referring to community dietitians via GP for ongoing management. And usually what that entails is, I suppose, looking at the milk ladder, which Professor Warren has already spoken about, and looking at that and getting, I suppose, milk back in the diet. Once, I suppose, there has been a period of time for, say, if it was a faltering growth baby with explosive loose stools, you want to make sure that actually baby is gaining weight and the stools have settled down before you're looking at reintroducing the food again. And bottom line, I suppose, with breastfeeding, it's something we want to encourage and support, and having multiple food exclusions don't really, I suppose, entice breastfeeding moms to keep up breastfeeding. So we know that there's not the evidence there for multiple food exclusions, so really it should be avoided where possible. And now, I suppose, if we're thinking of our formula-fed babies and non-IgE mediated allergies, so those babies who are on a standard infant milk, maybe they've tried a few of the standard infant milks, which is often the way, and they're still having their problems of, lots of loose stooling, poor feeding, faltering growth, maybe some skin problems. those are the ones that I'd be saying, okay, maybe we do try an extensively hydrolyzed formula. So again, there's lots available on the market. They do taste and smell very differently to regular infant milk. If anyone has ever come across them, you'll know that. So often what we say, I suppose we can try give them straight first of all, but if they're having trouble, parents are having trouble introducing them, we can do kind of a gradual titration over the course of 2 or 3 days until baby adjusts to the taste and smell. So again, it would be a trial period of 3 to 6 weeks. And then after this, we would look at a gradual reintroduction of the standard infant formula to confirm the diagnosis. And this is something that often parents they can be quite reluctant to try, but it is important in, I suppose, gauging, is it the milk that's causing the problem, or is it something else not related? And then I suppose the soya milks, soya formulas, not generally recommended for the infants under 6 months because of the phytoestrogen content, and that often, I suppose, babies who react to milk will react to soya as well in this non-IgE group. Goat milk, not recommended either. And I suppose the dairy alternatives available in the shops. So they said things like the oat milk, almond milk, pea milk, they aren't suitable for infants at all, really, under 1 to 2 years. And I suppose if we want to take a look at the nutritional comparison here, so if you think of your baby who is maybe having a little bit of trouble gaining weight, for the amount of calories in breast milk or a breast milk substitute formula, they would want to be drinking 4 times the amount of almond milk, which isn't really possible. And then also, I suppose our protein content is a lot less in the dairy alternative milks, and calcium, so many of them aren't fortified. So yeah, I would be avoiding those in the infant population group. Probiotics and eczema, something that sometimes comes up in clinic. Again, it's an area where there isn't a whole lot of evidence, and the evidence is generally not the best quality. But at the minute, we think there may be a role in prevention of eczema in infants if taken during pregnancy and while breastfeeding. Again, this is probably only going to be relevant to maybe those higher risk infants where maybe mum has another child with eczema and is eager to try something that may work. Again, emphasis on, I suppose, may. There is no evidence for probiotics in the treatment of eczema. So once the eczema is there, those probiotics probably aren't going to do much for it. And there's no evidence for probiotics in the prevention of food allergy. And I suppose just worthwhile to say that there's still a lot we don't know. There's many different strains of probiotics and how they work for some people, and how that same strain may not work for another person is just important to consider. So yeah, weaning and skin problems, similar to photos that you've seen already. I suppose in relation to this, I think, again, it is important to think of maybe your babies who are more higher risk of allergy versus the babies who are less high risk. And I would say, I suppose, food play is developmentally important in that children do get a chance to, I suppose, feel the food and get to know textures, and especially, I suppose, if there are fussy eating groups of infants out there, having the opportunity to actually touch the food and not have it kind of thrown into the mouth can be important. But I suppose in those group of children that are at high risk of allergy, so do have eczema or do have another food allergy, that would be the group I'd be saying that maybe limit it, and spoon feeding would be your best bet. And again, because this is often something that comes up in clinic, the parents often saying that after having like spaghetti bolognese or apple puree that they break out in a red rash across their face. That is more than likely not an allergy, and usually due to, I suppose, the acidic nature of the food. So tomatoes and fruits can be quite acidic, which can irritate the skin, as we know. So a little bit of a summary. So there is a lack of evidence at the moment for the use of dietary modification in the treatment of eczema. And really, I suppose it should be just that group of patients. Like first line would be treatment with your emollients and I suppose steroid creams, and going on from there if needed under the care of a dermatologist. And then I suppose if there is other symptoms, so usually I suppose gushy symptoms, but also in the non-IgE allergy group can affect growth in the skin, then we might be considering a dietary exclusion there. So important to have, I suppose, gut and skin symptoms present. Really important to establish a trial period, and then to aim to reintroduce to confirm the diagnosis in the case of non-IgE allergy. And then lastly, it's important to find suitable diet alternatives. So we don't want to take the whole food group out and not have something to replace it with. And I thank you for listening. I have included some useful resources there, and I would welcome any questions.